You're listening to This Week in Cardiology from theheart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or, Alexa, what's my flash briefing? I hope you'll join us.
Hi, everyone. This is John Mandrola from theheart.org Medscape Cardiology, and this is This Week in Cardiology for February 25th, 2022. This week, FDA approval of the CardioMEMS device, statins, ventricular tachycardia storm, fish oil, and atrial fib risk. So let's start with heart failure therapy. Well, the normal way to take care of patients with heart failure is to use guideline-directed medical therapy and then manage diuretics so as to maintain fluid balance and keep people out of the hospital. Diuretic management typically turns on clinical signs and symptoms like weight, edema, etc. So here's a new proposal. A paperclip-sized device placed in the pulmonary artery during this minimally invasive procedure. This device is capable of monitoring pressure changes and remotely transmitting these daily pressure readings to a patient's clinical team. The idea would be that this would be better to manage patients than standard care. Now, this device is made by Abbott and it's called CardioMEMS. And it already has a specific indication based on the 2011 Champion trial. Champion randomly assigned 550 patients with New York Heart Association functional class 3 heart failure, irrespective of the EF, and the patients had to have a heart failure hospitalization in the previous 12 months. Champion found a significant 28% reduction in heart failure hospitalizations at 6 months, but the study was not powered for mortality. Now, after failing at FDA initially, the FDA finally, in 2014, 3 years later, approved CardioMEMS for this very specific indication outlined in Champion. You had to have class 3 heart failure and a recent hospitalization for heart failure. Again, that's a pretty specific indication, and if you're the makers of a device, you want to be able to use it in less ill patients who have more general indications. Also, of course, if the device works as advertised, it would be great to expand to indications. So the makers of the paperclip-like device sponsored another trial. This trial was called GUIDE-HF, and I've discussed it before on the podcast. Lancet published a GUIDE-HF trial in August of 2021, and it was simultaneous presentation at ESC Congress. Now, GUIDE-HF randomized 1,000 patients, it's double the size of Champion, to either an invasive arm using the device versus standard of care. Randomization was after implanted the device. The treatment arm used data from the device. The control arm was standard of care, even though they had the device implanted. Patients were blinded to the treatment assignment, but clinicians were not. Now, more on that in a discussion. Entry criteria in GUIDE-HF was broader than Champion. Patients could have class 2 to 4 chronic HF and either a recent heart failure hospitalization or an elevated BNP. The primary endpoint was a composite of 3 things: all-cause mortality, heart failure hospitalization, or an urgent heart failure visit. It was assessed at 12 months. Now, briefly, patients were 70 years old, about a third had class 2 heart failure, 2/3 had class 3. The mean LVEF was 38 to 40%. Now, here were the results. Recall that there were about 500 patients in each group. There were 253 primary endpoint events in the treatment arm, and that was presented as 0.56 events per patient year. Then there were 289 primary endpoint events in the control arm, 0.64 events per patient year. The relative risk or hazard ratio was 0.88. That's a 12% reduction. Confidence intervals range from 0.75, that's a 25% reduction, to 1.05, a 5% risk increase. The p-value was 0.16. 40 patients died in the monitoring group versus 37 in the standard care group, so obviously no signal of mortality benefit. This was a solidly non-significant primary outcome. Urgent heart failure events, heart failure hospitalizations, and mortality were also non-significantly different when taken as single outcomes. So you'd guess that this would be an easy decision for the FDA. It's a pricey, invasive device that did not reduce clinical outcomes in a multi-center RCT. You could also add that even if you want to ignore the p-value, the reduction of 12% was modest, and it was driven by the softer endpoint of heart failure hospitalizations, not mortality. But no, it was not to be. GUIDE-HF actually underpinned the FDA approval of an expanded indication, an indication that's expected to expand device availability to 1.2 million more Americans. That's right, approval. I know you are puzzled. You wonder, Mandrola, did you misspeak again? Well, how did this happen? The authors provided a, quote, pre-COVID impact analysis of the primary endpoint and components. I'm not joking. They say it was a pre-specified COVID-19 sensitivity analysis to compare events before COVID and during COVID. Now, I'm not sure how this could be pre-specified because the trial started in March of 2018 before anyone ever imagined such a pandemic. The issue, the authors say, is that during the pandemic, event rates decreased in the control arm, and that narrowed the treatment effect. And the pandemic affected about 28% of total follow-up time. Now, they also say that this analysis suggested a treatment interaction. However, the p-value for the treatment interaction was 0.11, way above the 0.05 threshold. The authors tell us that this special analysis was endorsed by regulatory agencies like the EMA and the FDA. And voila, the special analysis made statistical significance. A hazard ratio indicated a 19% reduction, and a confidence interval ranged from 0.66 to, get this, 1.00. And the p-value was 0.049. The effect was driven by a 24% decline in heart failure events, with no significant contribution from lower mortality rates. The makers of the device said this in a press release, quote, results of the GUIDE-HF trial supported the expanded indication. Okay, my comments here. First, I'm dismayed by this analysis, the regulatory agency's allowance of it, and the expanded approval of this device. First, the obvious issues with this special COVID analysis. I may be wrong, but I see it as a post hoc analysis that at least gives the appearance of fishing for a positive result after the main analysis. I find it extremely dubious, and I'm not persuaded by the author's explanation. I mean, why would the control arm be more affected than the treatment arm during a pandemic? And if you're going to posit a heterogeneous treatment effect, why isn't the interaction p-value significant? Second point, you clearly have a non-significant result in the primary analysis, and even if it were significant, the effect size was small and driven by heart failure hospitalizations. Third, even if you let the COVID post hoc analysis pass, it barely meets significance, and again, it's driven by heart failure hospitalizations. Fourth point, I cannot find where the authors tell us about total hospitalizations. Now, this is crucial because these are older patients with multiple comorbidities, and reducing heart failure hospitalizations is only an important outcome if it substantially reduces total hospitalizations. This was the problem in the Emperor Preserve trial with empagliflozin. Heart failure hospitalizations were reduced, but represented only a small number of the total hospitalizations. Now, the fifth problem with this trial, it's single-blinded. This means clinicians at enrolling centers knew the treatment assignments. Hospitalization, of course, is a clinician's decision, and the clinicians who participate in this trial are most likely proponents for the device. And you look at Table 2 in the Lancet, which breaks out the composite by the three components, mortality, urgent heart failure visits, and heart failure hospitalizations. It's heart failure hospitalizations that shows the biggest delta. It is the most sensitive to a clinician's decision. Now, this is not a nefarious thing. It's a normal subconscious human bias. When this trial came out, Lancet allowed this sort of spin. I said that it really tempted me to be cynical. Well, now the FDA has allowed the spin, and it's depressing that this happens in clinical science. Keep in mind also that more than half of the authors have declared financial relationships with Abbott. I won't say any more than just to say that. Now a rebuttal to people complaining about me complaining about the FDA. Some of you may say, come on, Mandrola, who cares if the FDA approves it? Doctors can look at the data themselves and see that there was very little benefit. Doctors don't have to use it. But here's what happens in real life. Abbott revs up the marketing machine. Industry knows that the best marketing tools are not ads or TV spots, but endorsement from key opinion leaders. So now what happens is that hospitals and docs who decide against using it because of its low value have to struggle against the fear of missing out. There'll be pressures to use it because it's new and invasive and all the cool docs are using it. The heart failure department across town, for instance, will be doing ads about how they're using it. This fear of missing out thing happens in electrophysiology all the time. On new devices and catheters and procedures, they get huge marketing support. Then the key opinion leaders use these devices. They might post their experience on social media, discuss their experiences at meetings, and then the situation becomes, if you aren't using these new things, you are less cutting edge. Okay, final comment. This was a long intro. This leads the podcast because it's important to remember that overuse of low-value care fosters underuse of high-value care, and it surely exacerbates the disparities that are already so dominant in United States healthcare. Second topic is statin recommendations. The USPSTF, United States Preventative Services Task Force, has published a draft document on the use of statins to prevent disease that is yet to occur. Now, the jargon term for that is primary prevention. This document updates the 2016 recommendations, and it's a massive meta-analysis and systematic review. It includes over 85,000 patients. And I've said this before, but I like the USPSTF because they're independent judges of evidence. Now, they conclude in this document with moderate certainty that a statin will clinically benefit adults who are aged 40 to 75 who don't have heart disease but do have one major risk factor, and their 10-year risk score calculates at 7.5%. They go on to say that the net benefit of a statin is at least small for those in whom the 10-year risk is 7.5 to 10%. Journalist Steve Stiles has a nice news summary. He points out that the USPSTF recommendations vary somewhat from the AHA and ACC guidelines in 2018. I would say not that much, but some. Some two key points. USPSTF found insufficient evidence to guide primary prevention statin use in elderly individuals. Again, as I often tell older people, the point of preventive therapies is to get old. Once you are old, there's going to be less benefit. Now, by the way, a sidebar here is I use the word individual because with primary prevention, they're not yet patients. This is an important distinction because with the creep of screening and lowering of disease thresholds, there are fewer and fewer individuals left. Modern healthcare tends to transform individuals to patients quite efficiently. The USPSTF and AHA documents also diverge on the use of coronary artery calcium in primary prevention. CAC is not part of the USPSTF recommendations, but it figures prominently in the 2018 guidelines as a sort of tiebreaker for physicians and patients who are on the fence about whether to start the statin drugs. Now, here is what the impartial USPSTF judges wrote about coronary calcium. They wrote that a 2018 review found that the addition of CAC score for risk assessment can improve both discrimination and reclassification. However, the authors noted that the CAC score could also result in reclassification in individuals who do not experience cardiovascular events into higher risk categories. It could also result in potential harms related to radiation exposure from the use of CT and, of course, downstream testing. And they also note the absence of studies on any clinical effects of risk assessment with coronary artery calcium. This is exactly what Andrew Foy and I wrote in our case against coronary artery calcium in the AFP journal, which I will link to. Now, I could not agree more with the USPSTF about CAC. Hardly a week goes by where an older patient that I see has had a CAT scan and is now worried sick about their coronary artery calcium. Or I see a person who had a stress test because of a coronary artery calcium score. Or a person gets a cath because of a coronary artery calcium score. The proponents of using CAC say it should be used for statin decision making. Okay, but in my humble opinion, they need to be more aggressive about messaging because in the real world, coronary artery calcium scores is a super efficient, fear-inducing train to more lucrative procedures for cardiologists and hospitals. All right, third topic, ventricular tachycardia storm. Electrophysiologists call VT that is difficult to stop a VT storm, and I think the storm analogy works. Now, this is a bit of a specialized topic, so I'll try to focus as much as possible on the general messages which center on neural control of the heart and interpretation of trials. JAMA Cardiology has published a sham-controlled RCT from the University of Pennsylvania group looking at autonomic modulation to stop VT storm. The first author is Tim Markman. The specific intervention here is called transcutaneous magnetic stimulation, and it can be used non-invasively and non-destructively modulates nervous activity in many disease states. It likely works by reducing sympathetic innervation. The trial was conducted at the University of Pennsylvania. They enrolled patients with at least 3 episodes of sustained VT in the preceding 24 hours. Patients were randomized to a single session of transcutaneous magnetic stimulation or sham stimulation. The patient and the treatment team did not know the treatment. The primary endpoint was freedom from sustained VT in the day following randomization. The transcutaneous magnetic stimulation device was placed close to the left stellate ganglion in the left neck. And for patients randomized to receive the true stimulation, it was delivered at 80% of the local motor threshold and a frequency of 0.9 hertz for 60 minutes. For patients randomized to receive sham stimulation, sham therapy was also delivered for 60 minutes. They randomized 26 patients. That's a small number, but remember, VT storm isn't a common problem. But during the 24-hour period following randomization, sustained VT recurred in 4 of 14 patients in the stimulation group and in 7 of 12 patients in the sham stimulation group. The difference was not statistically significant. Some secondary endpoints, however, favored the treatment arm. For instance, the mean number of episodes of sustained VT after 72 hours was lower in the transcutaneous magnetic stimulation group compared with the sham group. They also looked at the physiologic effects and found that among those not receiving vasopressors, 4 patients in the stimulation group and no patients in the sham stimulation group had evidence of peripheral blockade, and none of the 4 patients had sustained or non-sustained VT within 24 hours after randomization. They also found no safety issues. Now, my comments here are that technically the primary endpoint did not reach statistical threshold of freedom from VT in the first 24 hours, but there were signals in the secondary endpoints that this non-invasive way to modulate the autonomic nervous system may hold promise for these patients. The emphasis here is on its non-invasive nature. The authors write that transcutaneous magnetic stimulation is a well-developed technique that exploits the plasticity of a patient's nervous system and can promote excitation or inhibition depending on the stimulation parameters. Now, I laud the UPenn team for systematically studying this. And you all might think I'm going soft because the primary endpoint was null and the authors point to these secondary endpoints which favor the treatment arm. But I think this is a different thing. A VT storm is a terrible, terrible condition. Well, sometimes, often perhaps, it's a terminal event and palliative care would be the best option. But sometimes VT storm is survivable, and even though patients are sicker than heck in the moment of the storm, they can survive for years afterwards if you can get it simmered down. Now, if we could have a non-invasive way to treat this condition, it would be a huge advance. Plus, I think we are in our infancy of knowledge about using neuromodulation for the treatment of arrhythmias. So I'd say that this technique warrants further investigation in larger trials. Now, the other thing to say about VT storm is it's a little like studying a viral infection. The outcomes are going to occur in days, not years, like most cardiovascular trials. So trials of VT storm seem quite doable to me. So kudos to the UPenn team for showing the way. Final topic is a brief one, fish oil and atrial fibrillation. The topic of fish oil and AFib is coming up almost every day in the clinic, sometimes more than once. My unofficial poll is that fish oil has overtaken aspirin for the drug that I most often deprescribe. Well, Circulation published a meta-analysis of fish oil trials in late 2021, and that meta-analysis found a clear increase in AFib risk. The Heart.org Medscape Cardiology has published an editorial from that paper. It's from Michelle Samuel and Stanley Natel, and it is an excellent editorial. Now, I have talked about this topic previously, but due to the clarity of the data and the commonness of fish oil use, I think it's worth a brief revisit. Now, the first thing to say is that if fish oil had clear cardiovascular benefits, it's possible an increase in AFib risk would be worth it. But fish oil doesn't have clear cardiovascular benefits. I mean, one trial, the Reduce It trial, was positive, but others have not replicated this finding. And yes, I know there's an infinite discussion about dosing and components of the capsule and choice of placebo controls. But the short story is there are no clearly discernible benefits that are obvious. Now, that is why this increased risk of AFib is important. The authors of the meta-analysis found 7 studies of 80,000 patients to follow up 5 years. And the use of marine fatty acid supplements was associated with an increased risk of AFib. The hazard ratio was 1.25, and it was a highly significant finding. And in the analysis stratified by dose, the hazard ratio was greater in the trials testing 1 gram per day compared with those testing less than 1 gram per day. In what's called a meta-regression, the hazard ratio for AFib increased per 1 gram higher dose of the fish oil tablets. And again, that speaks to a dose-dependent effect. And I can't explain why this is, but it's a clear signal. Therefore, in patients with AFib or who are at risk for AFib, without monster levels of triglycerides, I've been recommending to patients that they save the money. Eat fish, not fish pills. So that's it for this week in cardiology. As always, I'm grateful that you listen. And remember, friends, if you like this podcast, please tell a friend, give us a rating, write us a 1-sentence review on whatever app you use. These sorts of things really help others find us. Until next week, this is John Mandrola from the Heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.